I really could talk for 20 minutes about his accomplishments, but I'll just mention a few. He's a professor of medicine at Harvard Medical School and currently serves as the chief endocrinology, diabetes, and metabolism at the Boston VA healthcare system. He is a star by any measure. He's published over 900 papers. His H index, which is a measure of how often his papers are cited, is meteoric. He's won countless awards, has several patents, has trained scores of trainees, has received all the recognition that you might anticipate of a leader in our field, including being a member of the American Society of Clinical Investigators, a fellow of the American College of Physicians, et cetera. Has been honored 4 different times with honorary PhDs at 4 different universities, and is extremely well funded. His particular area of interest is, as you can see from the title of his talk, non-alcoholic fatty liver disease and NASH. And today his comments will be, the title of his talk is NASH as a Prevalent Metabolic Condition, Diagnosis and Emerging Management Options. So we're honored, Dr. Mantzoros, and the stage is yours. Thank you.
Yes, thank you, Dave. It's a pleasure to be here virtually and give this talk. And I hope we'll have the opportunity to meet in person in the future. I decided to talk today about a topic that many may find not conventional for endocrinology and diabetes. But I wanted to talk about non-alcoholic fatty liver disease and non-alcoholic steatohepatitis for a few reasons. Number one, it's an epidemic. It's an epidemic of the 21st century. 30% of people have more fat in their liver than they should have. Number two, most of the time goes undiagnosed and not treated. And number three, although most of us believe that it belongs to gastroenterology, I think that we own it. It's a metabolic condition, and we need to be more vigilant and start treating it. The field is evolving very fast, and I'm planning to give you an overview of where we are clinically, and then I'll go over physiology, and then over therapeutic opportunities and research opportunities in the future. So my group at the VA works primarily on new technologies for diabetes and artificial intelligence. At BI, my work has been on obesity and its comorbidities. And one of those comorbidities is not only diabetes and cardiovascular disease and chronic kidney disease, but now we realize that it is NASH. So I'll show results of data that we have in the past 2 years about adipocyte-secreted hormones, about gastrointestinal hormones, about myokines, and how they relate to non-alcoholic fatty liver disease and NASH. So what is non-alcoholic fatty liver disease? It's a negative term. It's a condition in which more than 5% of fat is accumulated in the liver. And this buildup of fat, according to the original term, is not caused by heavy alcohol use. Now, I will show you later that we have more exclusions. It should not be due to iron, hepatitis, autoimmune conditions. So we are learning more about this condition. And we believe that this is not, a negative term is not appropriate anymore. So I have proposed this metabolism associated fatty liver disease, because this is a metabolism condition, this metabolism condition. So we start with more fat in the liver in a simple explanation of what happens. The body realizes that this is foreign, sends macrophages to phagocytose it, inflammation ensues. And then if we lose weight or if inflammation doesn't work, then the disease does not progress. But chronic inflammation leads to steatohepatitis, inflammation. And then in about 20% of the cases, this leads to scarring, fibrosis, liver cirrhosis, right? And then hepatocellular carcinoma. So this is a simple overview. But most patients, as I'm going to tell you, have obesity and the metabolic syndrome and will die from metabolic complications, cardiorenal, liver, and CVD. So I'm going to tell you in a few minutes that this is part of the metabolic syndrome. All right, how prevalent is the condition? So among diabetics, and I know that, right, this is diabetes in endocrinology grand rounds, right? 70% of the people in Europe, 50, 60, 70% of the people in the USA, 7 out of 10 diabetics who come to my clinic have non-alcoholic fatty liver disease. Most of us, unfortunately, don't screen or don't even think about it, right? So this is a new field and we need to change our attitude, right? It's highly prevalent and very expensive. It goes undiagnosed. So more recently, a group of us representing professional societies. I represented the endocrine societies, other represented the American Diabetes Association, the Obesity Society, the Gastroenterology, American Gastroenterology Association. We put together a group. We wanted to see what doctors out there know about NASH. So we sent randomly 24 questions on screening, diagnosing, and managing NASH to about 751 participants, gastroenterologists, hepatologists, endocrinologists. Well, what did we find out? Well, those are experienced doctors, on average 20 years in practice, right? More than 50% PCPs. What did we find out? Answers were correct in about 50% of the time. So this was random. And we realized that indeed, we don't know how to treat and how to diagnose the disease. So we put together a call to action paper that we published at the same time in Metabolism. By the way, I'm biased as the editor-in-chief, but it's a very good journal. Think about it for your good papers. Our impact factor is up to 8.8 now, and we are going up. It will be 9.8 next year based on data that I have. We put it in gastroenterology, obesity, and diabetes care. And we said that, again, this is a prevalent condition. It goes from Nafld to steatohepatitis and cirrhosis. We need to be aware of hepatic manifestations and comorbid metabolic conditions. We need to screen at the primary care level and the endocrinology level. 55 liver centers in the USA are not enough to treat 80 million Americans who have more fat in their liver than they should have. We need to diagnose it early, and we need to optimize patient management consistently, timely, and accessibly, right? So whom should we focus on? Primarily type 2 diabetes. As I told you, 7 out of 10 diabetics have Nafld. 8 out of 10 obese people have Nafld. Metabolic syndrome, the more the features, as I'm going to show you, the higher the risk. Advanced age, and if you see any red flags in your Chem 20 or other laboratories. So what do we know today? We just published this month, this is hot off the press, paper from the same group of experts in gastroenterology on what is now the status of screening and treating. So primary care endocrinologists, they should identify patients at risk, 2 or more metabolic risk factors, type 2 diabetes, steatosis by any imaging, or high aminotransferases. First, we rule out alcohol intake. We need to rule out hepatitis B and C. We need to rule out autoimmune problems or iron problems. And if we identify them with these tests that I show here, we refer to hepatologists or treat in our clinics if we are comfortable treating in our clinics. If everything is negative, then we need to use one of the imperfect. We recognize these tests are imperfect, but we have a few tests that are FDA approved. One is FIB4 that we used in our clinics. I put it on the computer screens in our electronic health record at the VA. When we do a Chem 20, this pops up so that we are more vigilant and we see it as the first test. If it is less than 1.3, 2.5 for elderly, then the person is low risk. And the negative predictive value is about 90%. So we feel comfortable that this is negative. But if it is intermediate or high, then we need the positive predictive value is only 60%. This is a gray zone, right? We need to either do ourselves elastography. This is inexpensive, easy to do. It pays to buy this and have it in our diabetes clinics. It's reimbursable, or sent to hepatology to be screened. And a hepatologist will do a biopsy. We cannot do biopsies in 80 million Americans who have fat, but that's all we have at this point. And then send them back to us for treatment, or they initiate treatment. And we'll talk about treatment in a few minutes. As I said, these non-invasive tests are imperfect. Their negative and positive predictive value is very low. About 30% of people remain unclassified. And we don't want to do MR elastographies or biopsies, because if we did biopsies in 80 million people, we would have 18,000 excess deaths in the United States every year, and dozens of thousands of hospitalizations. So we don't want to do that. So what we need to do is to develop better non-invasive scans. And the field now is moving in 2 or 3 directions. One is add more simple tests to what we have. FIB4 is based on age, and so 2 or 3 tests from Chem 20, but I don't think we are going to get there. We need to do less expensive, better MR elastographies. And again, it's expensive. Not everybody can do that. We had another idea, and we published on it and we patented it, is instead of having the bottom-up approach, we have a top-down approach. So what did we do? We got all the hormones that in our previous papers we thought are associated with Nafld. So leptin is higher, adiponectin is lower. You expect this, we expect this, right? This is an insulin sensitizer, it's lower. I'm going to show it to you. Follistatins, inflammatory markers, and fibrosis markers. We did lipidomics, we did metabolomics, all the data from electronic health records. And we asked powerful computers to utilize neural networks and machine learning to come up with a simple algorithm. So we think that this is the future, to get as many pieces of information as we can from proteomics, metabolomics, lipidomics, the clinical record, and come up with a simple algorithm that we can use as non-invasive test in the future. So this is work in progress, non-invasive tests that are needed. All right. Let's now go over physiology, and from physiology to novel diagnostics and therapeutics. As I said, this is a disease where abnormal fat accumulates in the liver. 20% of the time, this moves to inflammation, macrophages, phagocytosis in the liver. Inflammatory cytokines follow the lipotoxicity. If we lose weight and improve inflammation, in a small percentage of people, this can regress, but most of the time, this is a progressive disease. And with more inflammation, we have fibrosis, extracellular matrix remodeling, hepatocellular death, fibrosis, cirrhosis, and liver failure. However, in early stages, most people die from metabolic complications and cardiovascular disease. Later stages from cirrhosis and liver failure that these days exceeds in number the numbers of liver failures and transplants that we are doing because of hepatitis or alcohol. So this is the new kid on the block. So what causes it? We'll talk about genetic predisposition. There is certain genetic makeup that predisposes us, our diet and obesity, and then what happens with diabetes, insulin resistance, how all these work together to cause the disease. And this is a graph that I use to elucidate what the problem is. So let's start from physiology. So the problem is more free fatty acids accumulating in the liver. And the fate of those free fatty acids is either to be stored as triglycerides or to be burned in the mitochondria. If we have more triglycerides stored, we have lipotoxicity, insulin resistance, inflammation, and macrophages trying to improve. But most of the time, as the disease progresses, This leads to fibrosis and other problems. So where are these triglycerides coming from? So they come from the diet, Western diets high in triglycerides and fructose, okay? Or when we develop lipotoxicity, insulin resistance, and obesity, they come from lipolysis or through insulin resistance from de novo lipogenesis. So all these provide opportunities for intervention. There is also genetic problems that lead to poor metabolism of these free fatty acids. And low adiponectin and insulin resistance leads to low mitochondrial function and less triglycerides being burned. Right? So let's go step by step. So what do we know about genetics? This is work in progress. But we know that adiponutrin, PNPLA3, is a molecule which is mutated in a significant percentage of Latinos, especially Latinos, who have intra-abdominal fat and intrahepatic fat. Increases hepatic fat content because it's more difficult for these people to metabolize it, leads to Nafld and NASH. Extremely rare in African Americans, prevalent in Latinos. Secondarily, we have other mutations that play a minor role. So glucokinase, HSD, other molecules that are important in metabolism. Genetics plays a role, however, in a single-digit percentage of the population. So 6% in Latinos, much less, we think, in Caucasians or African Americans. So what is the elephant in the room, pun intended? I'm sorry for this, but this is the big problem, is obesity. The prevalence of obesity goes up in our society over time. And this is followed for the prevalence of diabetes going up. But something that most of the time is not on our radar screen is that the prevalence of Nafld goes up. And it is more than twice the prevalence of diabetes. So risk factors, obesity, and all the comorbidities, hypertension, diabetes, hyperlipidemia. And as I told you, pretest probability 70–75%. The problem is that most of the time, when a diabetic with Nafld comes to our clinic, they are asymptomatic. They are not going to tell us anything unless we look for it. And when they are symptomatic, they have symptoms that are non-specific, like fatigue, malaise, right upper quadrant discomfort. And it's probably too late when people develop symptoms of cirrhosis and terminal disease. So risk factors. Diabetes is by far the strongest risk factor of not only having Nafld, but also having fibrosis and dying from NASH. Age, every year, risk goes up by 8%. Hypertension, risk goes up by 20%. Obesity, BMI more than 30, risk goes up 9-fold, 900%. Diabetes goes up 18-fold, 1,800%. Very important. And if we have not only one, but more than one risk factors of the metabolic syndrome, components of the metabolic syndrome present, risk to develop and die from Nafld goes up. So this is survival. The first line, the green, no metabolic syndrome, one component, 2, 3, 4 components. Survival goes down to 40%. So this is a metabolic condition. And obesity, as I showed you earlier, is not only linked to diabetes and metabolic syndrome, chronic kidney disease, and cardiovascular disease, but the new kid on the block, which is Nafld and NASH. So how does it contribute to lipotoxicity? I showed you earlier. What can we do about it? Is each and every obesity the same? No. Why is this happening? Why is the problem happening? So this is my interpretation of the data out there. We published it in an editorial a couple of years ago. This is a normal person, and we are genetically, epigenetically endowed with a certain amount of storage space for triglycerides in our body. If we exceed this, okay, or some of us, are more fortunate, they have more space. So we eat more, if you have more storage space, fat goes where it is supposed to go in sub-Q adipose tissue. There's nothing in the muscle, nothing in the liver, metabolically healthy obesity. 20–25% of the obese population out there. They may progress over time. When do they progress? When the amount of triglycerides that needs to be stored exceeds the storage space. And then fat goes to muscle and causes insulin resistance, to the liver, causes Nafld, non-alcoholic fatty liver disease. The same is true also in the opposite end of the spectrum, lipodystrophy. In lipodystrophy, people are lean, right? But they have no adipose tissue storage space. So the fat will have to go somewhere. And again, it goes to muscle and causes insulin resistance, and it causes to the liver and causes Nafld. So we have to address lipodystrophy, rare condition, but important determinant of metabolic abnormalities and metabolically unhealthy obesity. So as I told you, obesity as a risk factor, 80% of the population, and then all the other components of the metabolic system. I told you that genetics is a small percentage. So what is the rest? Lipodystrophy is rare. What is the rest? We thought that an important factor may be sarcopenia. As we grow older, our muscle mass goes down. So this is from an epidemiology study that we just completed, 10 years, 2,500 people followed over time. So this is low muscle mass, odds to determine non-alcoholic fatty liver disease. These are people with the highest muscle mass. So 50% risk to develop Nafld. If you have high muscle mass, however, and central obesity, your risk goes up. If you have high muscle mass and low central obesity, your risk goes down. So there is an interaction of the two, low muscle mass and obesity. And this interaction predicts not only non-alcoholic fatty liver disease, but 10-year risk to develop cardiovascular disease. All right, let's go step by step now, lipodystrophy, and then obesity and sarcopenia. So we've done a lot of work on leptin. We started with animal studies, and we have reported a long time ago that leptin is very important, not only in metabolism, but also to regulate neuroendocrine function in leanness and anorexia nervosa and hypothalamic amenorrhea. We realized that through human physiology, the biology of leptin is different in humans, is not as expansive as this slide shows. And in essence, it regulates reproductive hormones and metabolism in leanness. Leptin does not work in obesity. So in obesity, we have high leptin levels, high BMI. In lipodystrophies or extreme leanness, we have low leptin. Right? And in lipodystrophy, as I told you, fat accumulates in the liver and muscle. So what happens if we give leptin to lean people, right? Non-obese. Leptin works perfectly fine. As leptin levels go up, in one study that we published in Nature Communications last year, fat mass goes down perfectly fine. In another study, it goes up as leptin levels go up, then we discontinue it, fat mass goes down and fat mass returns. So it's a perfect anti-obesity medication because it affects only fat mass, but it works only in lean people. Obese are leptin tolerant. So we have tried a long time ago, and more recently we completed more studies, leptin to treat lipodystrophy. So this is a lipodystrophic subject. You see the abdomen is protuberant. There is non-alcoholic fatty liver disease. And when we treat people with congenital complete leptin deficiency or HIV lipodystrophic subjects, we shrink the fat in the liver. People have less waist, decreased waist to hip circumference. They improve their insulin resistance. Triglycerides go down, glucose goes down, and leptin is now approved for the rare condition of congenital complete leptin deficiency, the tip of the iceberg, but not for HIV lipodystrophy or partial lipodystrophy. So we wanted to see more recently what happens with partial lipodystrophy and fatty liver disease. So this is a normal person, normal fat stores, adequate leptin, healthy liver, reduced fat stores, low leptin, relative leptin deficiency, metabolic disease, fatty in the liver. And when we give leptin in this uncontrolled prospective trial, we improve hepatic injury, indicating that in addition to improving insulin resistance and triglycerides, we decrease fat mass in the liver and we improve the liver. health. So, okay, this is fine. This is a small percentage. Let's go now to the vast majority of people. In the vast majority of people, 80% or more of people who have Nafld, this is the big problem: obesity and diet. Hepatologists try to target fibrosis. All the trials have failed today. Inflammation, we are making some progress, but we think that the money is here in metabolism. We need to act early and address the problem early, and that's what we have proposed. So this is a paper we will publish in the next month in Endocrine Reviews, an overview of the current approaches to the treatment of obesity. It's a long paper, it's like 60 pages in Endocrine Reviews, but it's very detailed analysis of obesity pharmacotherapy. I told you about leptin. We realized that gut secreted hormones or peptides are very important. I'm going to tell you a few things about this. I'm going to tell you a few things about SGLT2s, and I'm going to tell you a few things about muscle secreted hormones. So where do we go today? Where are we today? Similar to each and every metabolic condition, we propose that we should have first lifestyle modification, diet and exercise. Surgery may have a role, and then which medications? Vitamin E, antioxidants, anti-diabetic therapies, anti-obesity therapies. Where do we stand? All right. So we studied in an epidemiology study in Greece, in fact, 2,500 people who either followed or did not follow, like it's a population, right? And we split the group in two groups, right? Half of them who were less adherent to a Mediterranean diet, and half of them who were adherent to traditional Mediterranean diet. And guess what? We found that 10 years later, right, people who were following the Mediterranean diet, their risk to develop Nafld was almost flat, no increase, and their cardiovascular disease risk was much less. Those who were not following the Mediterranean diet, their risk would go up 40% or 60%, 65% in men. So how do we go from observational studies to interventional studies? And this slide summarizes, and we put together meta-analysis. When we approach a field, I have my fellows do a meta-analysis of what is known before we move forward to the next stage. So low carbohydrate diet works very well in the beginning, but over time, people catch up, there is no difference. Mediterranean diet results in about 4.4% on average decrease in fat in the liver, and this is now what is recommended for the treatment of Nafld. So either Mediterranean diet, which many Americans cannot follow, or a DAS diet, which is more consistent with the American lifestyle. This is lower in total fat and salt, and rich in fruits and vegetables and legumes and fresh foods. The Mediterranean diet also has fat in it, but the fat is not animal fat. It is fat from plants, extra virgin olive oil, rich in monounsaturated and polyunsaturated, and very poor in saturated fatty acids. It's rich in fibers and polyphenols, and this is what makes the difference. So even if we avoid animal fat and we focus on plant foods, there is some of them that are not as good. So this is risk for Nafld, this is risk for cardiovascular disease. Which ones are not good? Well, the usual suspects. We are planning to publish this is in press. So fruit juices, high in fructose, canned food, colas, potatoes fried. What predisposes to metabolic syndrome is bad for Nafld and NASH. So this is what we need to avoid. Healthy diet, plant-based diet, avoid food items. All right, so how do we create the recommendations now? Hepatic steatosis, we recommend weight loss more than 5%, avoid alcohol, avoid fructose, Mediterranean diet, more weight loss if we have steatohepatitis, and then late stage cirrhosis, modest calorie restriction. We need to regulate protein intake, small frequent meals, and of course, no alcohol, no fructose. What about exercise? Well, what do we recommend for diabetes or metabolic syndrome works for NASH? Aerobic or resistance exercise aiming at 150 minutes per week, or moderate intensity exercise. We are publishing in Metabolism and a meta-analysis next month, but this is the bottom line. Weight loss surgery and medications. So for weight loss surgery, right, or decreasing weight loss, if we were able to decrease weight loss for more than a year by more than 10% of our body weight, 90% of NASH, we would have resolution. Steatosis improvement, 100%. What is the problem? That with currently available medications, we cannot have more than 10% weight loss over 1 year in more than 10% of our people. So we need either surgery, which is very effective, or new medications that are very effective. In our group, we study, in addition to adipokines, myokines, and these are targets for the development of new anti-diabetes, anti-obesity, anti-Nafld medications, polystatins and activins, block myostatins, right, and activins, and they increase muscle growth. We do physiology studies in our group, interventional studies, diet, exercise, metabolic syndrome. A number of papers over the past couple of years to define the physiology, because this is a target. Now, more than 2 companies develop medications to increase muscle mass. Another area of interest in our group is GI secreted peptides. In addition to ghrelin and PYY, the old kids on the block, we focus on the proglucagon family of peptides. We have 7 of those, and we studied them in detail after surgery and physiology, like different diets, peros or IV, and exercise. And we're trying to see whether factors that improve metabolic syndrome would change these hormones. And we focus traditionally on GLP-1. This is a target for medications. GIP, which is now the next phase, duals. And then we'll have triples or quadruples. And there we think that glucagon or oxyntomodulin and glycemtin will play a role. And how do they work? Now, we do a lot of physiology studies in humans. Our colleagues who do animal metabolism, rodents, they will tell you that they act at the level of the hypothalamus, which is the homeostasis system for regulating food intake and energy expenditure. Increase anorexigenic, decrease orexigenic neuropeptides. In humans, we are finding that it's not only the hypothalamus, it's the reward system. And we do fMRI studies in response to highly desirable or less desirable foods. And we see which areas get activated when we give these peptides and what the effect is, the physiological effect. So we see that we make people feel rewarded by food earlier. And these are the reward centers that we activate. And also there is a small effect on the prefrontal cortex. So people are more attentive to what they eat. So if we go to a meeting and instead of grazing out there, people are more attentive. Or if they open their refrigerator and they see plenty of food in societies of affluence, they're more attentive. So in humans, we think that it's not only the hypothalamus, but also the reward system and the cortex. So what happens with these molecules after bariatric surgery? So we just completed the study, we submitted it to Lancet Endocrinology. We'll see what happens. 12 years of follow-up is, I think, the longest study to date. So we see that 12 years after bariatric surgery, irrespective of whether we have FSG or Roux-en-Y, people remain at lower body weight. Their kidney function, liver function, cardiovascular, we have a detailed cardiac evaluation, remains down. And all these beneficial effects are mainly associated with gut peptides. Secondarily with leptin and adiponectin, but not with muscle secreted peptides. What are the next steps? We have now collaborate in the context of a multi-center bariatric surgery study for Nafld and NASH, BRAVES, and we develop in the lab, we help develop a surgery and a pill. So trying to create a pill that would be coating the GI tract and would change the levels of these GI secreted peptides. All right, what about medications we have for metabolic conditions? Metformin is not recommended, does not work. I'll show you some data. What about statins and thiazolidinediones before we proceed with more novel medications? So again, this is a meta-analysis. We meta-analyzed metformin in diabetics, non-diabetics. There is no efficacy in Nafld. It is not recommended. What about statins? We put together a meta-analysis of the effect of statins on Nafld. We have about 4-5% decrease in fat. In steatosis, we improve activity score, less so with fibrosis. It is recommended. So if you have someone on statin, a diabetic who has Nafld, keep him on the statin unless this person develops end-stage cirrhosis and other problems. So it is recommended. What about thiazolidinediones? I think this is a gem which is unrecognized. So what do thiazolidinediones do? Like pioglitazone, right? Only 8% of our diabetics use pioglitazone today, on average, nationwide. What do PPR gamma modulators do? They expand sub-Q adipose tissue, more storage space, decreased insulin resistance, decreased inflammation, decreased glucose triglycerides in the circulation, decreased fibrosis, steatosis, inflammation in the liver, and they have an anti-inflammatory effect. So where do we stand with these medications? I'm sorry for that. I had a slide which does not project. Lanifibranor, which is a pan-agonist, is now in phase 3 clinical trials. Pioglitazone works in humans, but has side effects. So I start with 15 milligrams. I may go up to 30, but I never go above 30. Why is that? Because of the known side effects. We all know that. So what is the field moving to? It's moving towards creating more selective PPR gamma modulators that they will retain the efficacy, but hopefully have less side effects. We tested one of these medications in an animal model, amylin diet, high in fat, fructose, cholesterol, what causes Nafld in humans for 36 weeks. We randomized the mice here on the basis of a biopsy, and then we follow them for 12 weeks. This medication decreases NASH activity score by expanding adipose tissue. Again, the expected mitochondrial function, browning goes up, adiponectin goes up, inflammation goes down, and improves fibrosis marker. So I think this is what we can do today for our diabetics. Think about pioglitazone despite the side effects. If there is no contraindication, more selective PPR gamma modulators, I think, is the future. Pioglitazone also works in studies in pre-diabetes or non-diabetics, but we cannot recommend them because they are not FDA approved. What about GLP analogs or SGLT2s? And again, a meta-analysis, we did not do that meta-analysis. 11 studies with hard outcomes, biopsy, ultrasounds, MRI, MR elastography. You pick your favorite GLP-1 analog, liraglutide, dulaglutide, exenatide. They decrease on average fat in the liver by 5%. They decrease NASH and inflammation significantly, but to date, there is no improvement of fibrosis. So they don't work in late stages. They work in the left part of the spectrum. We think that with more significant, more potent GLP-1 analogs like semaglutide or others in the future, and longer treatments, we may affect fibrosis, but we are not there yet. So we thought in the lab, what if we combine the two? Are GLP-1 agonists acting in parallel with PPRs, right? Are the mechanisms different? And if they're different, can we combine them? That's the idea. So GLP-1 analogs work in the liver by decreasing hepatic glucose production, PPRs, fatty acid uptake. So same model, animal model, randomization, we follow for 12 weeks, detailed metabolic insulin resistance biochemical measurements, and also metabolomics and lipidomics. Well, both, either liraglutide or elafibranor, improve activity score and steatosis. They improve all the outcomes. And what do we learn from metabolomics? This is the control group, chow, normal diet. This is the high-fat NASH diet. And this is what happens with liraglutide, improvement of these metabolites This is what happens with PPRs, improvement in different metabolites. So liraglutide works with improving mainly carbohydrate metabolism and has moderate lipidomic alterations. PPRs work by restoring hepatic lipidome and having an effect on oxidative stress and inflammation. So we think that there is a future for combination of PPRs and GLP analogs in the future. What about SGLT2s? Again, start with meta-analysis of SGLT2s. What is the effect in steatosis? -2%. So it's half of what we see with GLP-1s, but there is some effect. And we wanted to see what happens at the animal level. We did studies in non-diabetics and diabetics mice. Very quickly, these are just published. In non-diabetic animal model, again, high-fat diet. What do we see? We see improvements in metabolic profile, improvements in liver function tests, in liver histology, and then ER stress goes down, autophagy goes down, and inflammation goes down. And this is a non-diabetic, the amylin mouse model that I showed to you earlier. If we give empagliflozin, we improve NASH. And in summary, in a graphical form, we improve autophagy through decreased lactosyl ceramides, and we improve SPMs, and through this we improve liver inflammation. So it's useful also for the liver if we give empagliflozin, but the effect on steatosis is about half of what the effect of GLP-1s is. So to summarize from our studies, GLP-1 receptor agonists, liraglutide, they decrease steatosis, they improve activation of hepatic stellate cells and inflammation, they regulate carbohydrate metabolism, they have the desired effects in hepatic steatosis and liver inflammation. SGLT2s, less of an effect, but still significant of autophagy, SPMs, they improve. PPR gamma modulators, we'll see more in the future in this area in NASH, I believe. They decrease insulin resistance, improve fatty acid oxidation, decrease inflammation. They have very good results. And then PPR alpha deltas, well, they work in mice through these mechanisms. They have not shown positive results in clinical trials in humans. And then we have the combination therapies, dual PPRs, triple PPRs, and then combination of GLP-1s and PPRs in the future. What about moving from metabolism to inflammation? We just published a paper, and this is an active area of research. We tried an AZD compound in collaboration with Pittsburgh and Vanderbilt. And we've used an animal model of Nafld and insulin resistance. And very briefly, because my time is running out, we improve using clamp data in those mice, insulin resistance, we improve inflammation. And if you look at the three groups of mice, controls, high fat and high fat with this antagonist of CXCR2, we improve fibrosis and the overall NAS score. So we can address, in a way, limited way, inflammation at this point, but there is a lot of work that needs to be done in this area. And in terms of fibrosis, we don't have any positive data from clinical trials yet. So where is pharmacotherapy for Nafld going to? So we have a lot of medications now, a lot of ideas to target insulin resistance and lipid metabolism. Less but significant number trying to target lipotoxicity and oxidative stress, inflammation, immune activation, cell death, and fibrosis. 60 medications are now in clinical trials in humans. It's an unmet clinical need. No medication has been approved specifically for Nafld or NASH, but we hope that at least half, statistically, of the 4 medications that are in clinical, in phase 3 clinical trials will find their way to our therapeutic armamentarium. And until now, for our patients, we need to have a couple of approaches. Number one, what we wrote and suggested in our paper, think about Nafld and NASH when a diabetic an obese person comes to our clinic. We need to screen at the primary care and the endocrinology level. We need to diagnose early, and we need to optimize management consistently, timely, and accessibly. We need to stop the disease early, before it becomes steatohepatitis and fibrosis. We also need to think that in addition to the known targets in metabolic syndrome, cardiovascular disease, chronic kidney disease, diabetes, when adipose tissue storage is exceeded, we do see insulin resistance, metabolic syndrome, microinflammation. We do see cardiovascular disease, fat accumulation in heart, chronic kidney disease, diabetes. We also have fat accumulation in the liver. And this leads to important disease outcomes. And most probably, the same medications, we may have more medications for the liver, but the same medications that work for metabolic syndrome and cardiovascular, kidney disease, or diabetes, namely SGLT2s, GLP-1, and what works also for Nafld, not only for diabetes. So clinical care pathway, we just pathways and medications, and this will be continue to be updated in the next few years to inform people out there about guidelines for Nafld and NASH. So mainstay, however, is prevention. Mediterranean diet, relaxed lifestyle, and exercise. And we wish we were in Greece or Italy, right, and live this beautiful lifestyle, but we can do what we can do here, but let's keep this in mind. So thank you for your attention. And this is a beautiful picture of my hometown where I spent the first 18 years of my life in Greece. Thank you, and I would be happy to take any questions.